My name is Shika Dunyo, and I'm the Director of Education Programs at NORD. I'll be your host for today's webinar on emergency medical protocols. This is a collaboration with the Rare Action Network and NORD's Education Initiatives Department. This webinar is a part of a series of free educational webinars for patients and caregivers. We're glad that you are able to join us today, and we hope that you join us for future webinars in the series. So I just wanted to take a brief moment to introduce you to NORD in case there are people on the phone who are not familiar with us. NORD is an organization that's committed to the identification, treatment, and cure of rare diseases through education, advocacy, research, and patient services. You can learn more about our programs, services, and resources and how to get involved by visiting our website, rarediseases.org. We offer a number of programs that can help you along your journey. We're also on social media, so if you are as well, you can follow us on Facebook and Twitter. I'd like to introduce my colleague, Tim Boyd. Tim is the Director of State Policy at NORD. In his role, he's responsible for public policy in all 50 states. Prior to joining NORD, Tim worked on the federal, state, and global level on policy surrounding HIV and AIDS. Tim, I'm going to turn it over to you.
Thanks, Shika. Hi there, everyone. And thank you for joining us. I'm going to kind of run through this issue of emergency medical services protocols for rare diseases at kind of a high level and talk about just generally when we talk about this issue from a policy perspective, what NORD is really concerned about. And then I'm going to also then turn it over to our guest speaker today, Darlene Shelton from Danny's Dose, to really get into the granular aspects of this. Danny's Dose has done amazing work on this issue, and they're really kind of a leader on this. And so NORD is hoping to support and kind of partner with them, but Darlene is really going to dive into kind of a first-hand experience about what this issue is all about. And then once Darlene does that, we'll kind of bring it back up to a higher level and talk about what's kind of happening next and what are some of the opportunities for all of you to get involved in this issue and take action in your state. So the basics of this problem is essentially that there are restrictions, and sometimes those restrictions are legal, are policy-based restrictions or rules that prevent emergency medical services personnel from administering or giving patient-carried medication. So your paramedic, sometimes the fire department, and other emergency personnel, if you say have hemophilia and you have hemophilia factor on you, if you have a disease like adrenal insufficiency and you have an adrenal factor on you, if you're in an emergency situation, that EMS personnel cannot provide you with that patient-carried medication. So the thing that will help you immediately, in many cases, in many counties, the 911 personnel, the emergency personnel, can't provide that to the patient. It's like against their rules, so sometimes there's actually those legal restrictions. Other times they could just be kind of norms, and the personnel prefer not to do that. They prefer not to take direction from the patients. In addition to that, in general, emergency services personnel, in addition, and ER personnel, ER doctors in emergency room departments, do not have access to rare disease information and treatment protocols, so that when rare disease patients are in emergency situations, they are often the ones who know their disease the best or know their loved one's disease the best, and they know what needs to happen medically to deal with this emergency issue. And oftentimes the ER docs and other EMS personnel don't know that, and they don't trust the patients enough, and they don't trust the families enough to rely on their word or the documentation that they have proving that issue. And so kind of in addition to the patient-carried medication issue within emergency departments is the lack of unified systems and information about rare diseases and about individuals' disease and their treatment protocols leads to poor outcomes, and it leads to situations where patients and families find themselves arguing with their ER docs, arguing with nurses about what is best for their family or their son or daughter, and not getting the treatment they need. And ultimately, not only does that lead to poor health, but it leads to increased costs, it can lead to endless frustration, and it really not only runs counter to what's best for the patients, but it runs counter for what the goals and objectives are of emergency medical personnel. In addition to those two issues, there's also in general just a lack of education and training on rare diseases among all types of different stakeholders. So that includes EMS personnel, that also extends to other public safety personnel, and is also pretty prevalent in schools. Just people who often find themselves working directly with rare disease patients, don't know anything about those diseases, aren't required to learn anything about those diseases or those patients when they do have one, say, in their school. And that can lead to kind of some of the similar issues I mentioned before, where just when in an urgent situation, in a situation where a patient, especially a child, needs help and needs a specific kind of help, the people that are responsible for providing that care aren't educated about the issue, don't trust the patients and families enough to do kind of what their experience tells them to do, and it creates a huge problem. Finally, underlying all of this, especially some of the ER and EMS issues, there's a huge problem with the kind of the billing structures around this issue. And oftentimes a rare disease patient, when they are in an emergency situation, they find themselves at an out-of-network hospital. They may not be aware of that, or because of their medical condition, they go through so many hoops with the ER docs and the nurses, they find that after that situation has been resolved, they have huge unexpected medical bills that could have been avoided had there been better policies in place to protect against those types of charges because of out-of-network rules, or if the emergency department was following the advice and protocols of that disease, some of those extra charges could have been avoided in the first place. So these four things are really kind of the landscape of issues that we're really concerned about, and we're trying to work with advocates and stakeholders across the country and various states to develop solutions for them. And we have a couple solutions that we'll talk to you about today. So in terms of current state efforts, I think we have a model in Missouri, a state that Darlene works really closely in. That photo you see on this slide, if you're on the webinar, is actually Darlene with the governor there in Missouri signing into law their EMS bill. That model in Missouri gave EMS medical directors the authority to provide education and medical directives for special needs patients in their region. And this also now includes the ability of an EMS to administer patient-carried medication. So what Missouri did is really exciting, and NORD is supportive of the efforts of Danny's Dose to try to take that to other states. And there's a few states that I mentioned here where that's potentially being pursued, and there has already been legislation filed this session, or will be legislation potentially filed next session. And we'll talk a little bit about those opportunities for engagement later on in the presentation. In addition to those state efforts, Danny's Dose is also pursuing federal legislation to kind of solve this problem across the board, at least in the ways that the federal government, the areas where they have authority, and we'll talk about that a bit as well. So that's kind of the general landscape. It kind of covers the contours of what Darlene's really going to get into. I do want to kind of throw it to her now and introduce her. So as I mentioned, Darlene is the founder and president of Danny's Dose. We're really excited to have her joining us on this webinar and presenting on this from her personal experience. She really kind of, as I mentioned, pioneered this in Missouri after kind of experiencing these problems with her own family, saw that legislation all the way through to enactment, and is now kind of taking that model to help families across the country. It can be very easy for someone to, once they've solved the situation in their state, to say, I've done my job, but that's not what Darlene is doing. She's really taking this and using her experience to try to help families across the country, and it's really great. So Darlene, I'm going to throw it to you now.
Okay, thanks so much, Tim, and thanks everyone for logging in. It's very exciting to get to share this information, and we really appreciate NORD supporting us so much. This first slide is a picture of our immediate family. We knew when we found out about these issues that we had to stand up and do something, as Tim said, and we're in it for the long haul and here to protect all patients with special medical needs. And I want everybody to always remember this is not just about hemophilia at all. This is for everyone who has any kind of specialized emergency treatment protocol to be able to receive that in an emergency to make sure that they are protected and safe and have prompt and proper care. You'll see in this next slide, this is Danny Noah, and he's the reason that our family was plunged into the rare disease world. At 11 months old, he was diagnosed with severe hemophilia B. It had been missed prior to that, even with terrible, terrible bruising, but he had his first bleed in his mouth at 11 months old, and so it was apparently clear something was wrong. The very first doctor's appointment, the doctor was very adamant. He said, you are an hour away from the nearest treatment center that knows anything about hemophilia. You never leave the house without this medication. You wouldn't have time to drive all the way back home, all the way to the hospital. That would be too long and it could be detrimental. So as a family who thinks way outside the box, a bunch of engineers and I do accounting, we made a plan. So we knew if he was in the car, there's an automobile accident, that we had to have emergency orders from his physician so that they would know what to do, what's the right treatment. We did a medical alert band on his ankle because, of course, it won't stay on a baby's wrist. And I created an emergency alert headrest cover that we always kept on the seat that his car seat was in. And then, of course, one emergency dose of his factor, which makes his blood clot, in a clearly marked bag. And so we believed that he would be protected. And until our rainbow-colored glasses were shattered, a very dear friend of ours who also happens to have hemophilia B was talking to my daughter-in-law, and we were talking about all our steps we had taken to make him safe in an emergency. And he said, well, that's a good plan, but it won't do you any good. He had been in an automobile accident, broke his right wrist, hit his head, had his medication there, could not convince the paramedics to administer his medication, was taken to the ER, could not convince the ER doctor to administer his medication, even though he could tell that that he pretty much knew he was having a brain bleed because of some vision issues and started to have trouble with speech. His wife got there, administered his medication, did the CT scan. He was having a brain bleed. She saved his life. They, as a family and an organization, proceeded to change regulations in New York, but only for bleeding disorders, and were successful after it took them 7 years, but then they stopped there. And so when he told us that, at first we really thought it wasn't true. I mean, it was the end of 2014. We thought there was no way in the world that could be right, and we started doing research, and we were very shocked that not only, yes, there are protocols, older protocols, but still they are there that prohibit administering patient-carried medications. And also, our paramedics are not at freedom to deviate from their standard protocols. So when you have a rare disease, that puts you in danger, because the number one thing that all of us with rare diseases need is for them to deviate from standard protocols. We don't fit in the box. And, of course, when it comes to medication, those are not located on an ambulance. They can't be. They're too expensive. There's too many different ones. It would be cost prohibitive, and it just isn't logical. And the same thing for ERs. So, and then it boils down really, as we've been working with the EMS individuals, really a lack of education that also causes a fear. And then they also have the fear of liability of doing the wrong thing, and then it's old protocols and they need to be changed. So it's just a little bit of confusion. And so we knew if we just stepped up and were willing to be part of the solution, that we could have a good solution. And when we started, we tried contacting some of the large national organizations, and I'll put in not NORD. We were not even connected with NORD at that time. But there were several organizations that do know the issue exists, and they were doing nothing. Basically, we were told it was too Herculean a task and could never be achieved. So that's just not what our family does. When it's life and death and it's common sense, we know that if you're part of the solution, a solution can be formed. So we created the Danny's Dose Alliance in March of 2015 and visited our capital for the very first time. So with the visits that we did, it created our mission and our goals. And one is to see these existing treatment protocols changed. And then two, we know that there's three parts to this. you can change regulations, but if you don't help educate the paramedics, then there's still going to be that fear and the unknown. So we have a huge dream and goal of launching a national paramedic education campaign. And then 3, we have to educate our families, each of you, on the roles that you have in being prepared and steps that you should take before an emergency ever happens. You know, that Herculean task, maybe it's big. Yes, it is big. It's still big. But if we all just work together day by day, we can do it. So far, in 3 years' time in Missouri, we were able to build a partnership with our state EMS association, and that is key. No, we don't want to come in with both barrels blazing and try to point fingers and accuse. We want them to understand that it's rare. We all had to learn. We need to be able to teach them. We need to help them realize that there's an issue and be part of the solution, as I said before. We have a great relationship in Missouri. EMS education started in 2016, and that was not really because of us. That was because of some great paramedics and one of our children's hospitals in the state that got some grant funds for that education, which is continuing. We were able to develop what we feel like is the best solution in the state, which led to our bill that passed in 2017. And we followed that later in 2017 with our first family education event on emergency preparedness, which was a lot of really great fun. We are still working on a standardized emergency medical orders form, which I'll talk a little more about in a minute, for our state, because one thing we want is uniformity across the state so that everyone knows their treatment will be the same. We were excited that Minnesota had a bill filed late in 2017. It was too far down the list to even be read in 2018, but it's ready to be refiled in 2019. And as Tim said, we are working in many other states. For those of you who are interested in the legislation side, I just wanted to put the main points. One of the things that we're looking at is an additional liability protection for the regional medical directors and for those paramedics, because when you change a protocol, that opens them up for liability, and we need to make sure they're protected. This in no way prevents litigation if they have actually done wrong or caused harm, with ill intent. And then on our particular bill, it also helps with some 911 services. And then, of course, it literally does state that a paramedic may administer life-saving patient-carried meds in an emergency. So we were very pleased with our legislation that happened in Missouri, and looking forward on that going on. The best solution that we developed in Missouri is for our paramedics and our ER physicians to be able to follow emergency medical orders of the patient specialist as the medical control. There's no way that they can know everything about all rare disease, but they all have plenty of training to carry out the orders if they just have those instructions in front of them. And of course, this would be for life-threatening pre-diagnosed conditions. We are not talking about just a random medication that is not a treatment for a life-threatening condition. And then, of course, that they be allowed to administer patient-carried meds. We are working, as we said, on the state level, but then also after the Missouri bill passed, I was contacted by a few senators and congressmen wanting to know if this is something and how that they could help with and how we needed to really promote this. So with the collaboration of the National Association of EMTs, we were given a bill proposal. Congressman Lukemeyer was the very first one to step up and agree to absolutely support a federal bill. And it is different than what state legislation would be, because there's some federal grant money that outlines requirements for treatment of children. And so our idea is to add additional requirements regarding patient-carried meds and special medical needs patients to those requirements. We have already been busy, although we only have our first draft, and we have about 28 more legislators that have said they are ready to co-sponsor as long as it stays in line with that draft. You'll see a list of also the national EMS associations and national organizations that we have partnered with and we are working with on a regular basis. The National Association of EMS Physicians recently reviewed and provided a new policy statement regarding patient-carrying meds and special medical needs patients. NASIMSO is working on the new EMS scope of practice updates, and we had a very good conversation, and you'll be happy to know that these issues are being covered in the new scope of practice. The American Academy of Pediatrics Emergency Services Division and U.S. Department of Human Health, two different divisions, we're working with them very closely, and they are very interested in this issue and have assured us that they want to be part of the solution. This is all very, very exciting to me. We really do have a lot of good individuals that really care deeply about this issue. I do want to make a note. You'll notice at the bottom of each slide, there's my contact information so that you don't have to worry about trying to hurry and jot it down. It's on every slide. And as far as the National Paramedic Education Campaign goes, for those of you who are online that work for or are part of a pharmaceutical company, a specialty pharmacy, in a medical professional, or a disease-specific group, to have a national education campaign, it's going to take all of us in a huge collaboration to create these educational pieces. The national associations can do the side that makes it EMS or CME accredited, but they also need the medical expertise to come alongside to make sure their education is true and correct. So if you would like to help be part of that effort, if you would be specific when you email me and say, hey, Darlene, I would like to help with the national education, I would love that. You'll see my email address in the bottom corner of this slide. Moving forward, family education and also your input. Our large goal is to have a family emergency preparedness education event in every single state every single year. Yes, that's a huge goal, but if you don't go big, go home. We would love to partner with your organizations to bring those education events to your conferences and to your state. So please, if you're interested in that, give me a call or send me an email. We also need your stories. Every time I have a meeting, I get the question, how often is it happening and to what extent? So we have created a survey, and if you have had a situation with a denial or a delay in treatment, would you please go online and fill out that survey? The most information that we ask for is your county that you live in, because that is important to see if the issue's happening worse in in a certain place. And you can give more. You can give your name if you want. And then we do have an area where you can give a detailed written account if you would like. And then also, I am putting together data to try to create numbers of how many individuals in the U.S. this actually affects. So far, I'm at about 20, and I'm at over 26 million Americans. So it's compiling quickly. So if you have a rare disease that requires any type of special treatment in an emergency, I really need you to also give me that information. And it doesn't have to be real long, just short, kind of to the point, so that I can add that to the count for how many different diseases and individuals across the U.S. this will protect. That's a short version. Tim and I want to really open this up for questions. So at this time, I'm going to turn this back over to Tim so that we can have a little bit of time for your questions.
Thanks, Darlene. That was really comprehensive. Thank you. So I'm going to pick up on kind of some of the next steps that you mentioned and talk about ways for you folks to get involved. First and foremost, as Darlene mentioned, you can contact her directly with the contact information she provided to share your story on this. I want to reiterate, because HIPAA is always watching, that sharing your story is absolutely voluntary. We're not requiring you as a requirement of participating and work with us to share your story. But if you feel comfortable and want to volunteer your experience on this, you can share that directly to Darlene. In terms of other ways to get involved, we are looking to expand these advocacy efforts into as many states as possible. And in order to do that, we need people, dedicated advocates and families in those states to help with those efforts. We're also looking to push forward federal legislation, and that's going to happen kind of in concert with the work we're doing in states. So in order to kind of coordinate all of that work, we really want to, NORD and Danny's Dose are looking to create a new coalition of both kind of advocates and also individual organizations to coordinate national efforts on this issue and help get these coalitions in individual states up and running and going. And so for all of you registered for this webinar, once we get that coalition going, and the purpose of that coalition will be to kind of have further discussion and insight and deliberations on all these issues Darlene raised. If you register for this webinar, you will receive information about that coalition and the next steps and how you can get involved with it. In addition, if you register with Darlene at dannysdose.com, once we have that information about the kind of the coalition calls and other opportunities for engagement, you will get it there as well. But at the minimum, if you're on this webinar, you're going to get that info. In addition, for many of you, if you haven't already, NORD sends out updates on this and other issues through rareaction.org, which you can sign up if you're not yet a member of the Rare Action Network. In terms of our action moving forward, this map, for those of you on the webinar, kind of outlines some states where there's already some preliminary discussions about this issue, and Minnesota was mentioned, where there was a bill filed this year. That bill is actually S1023, and Darlene, correct me there if I'm wrong. That was filed and didn't actually pass this year, so we'll have to be restarted next session. But these other states are areas where there's already kind of some interest in pursuing bills or other efforts similar to Missouri that we're looking to get involved in. That's not this map is not limited to where we're going to be involved, but that's kind of where there's already been some discussions. And so if you live in one of those areas that you see highlighted, stay tuned, because we're hoping to have some specific opportunities for engagement for you in the near future. So with that, we made an effort to kind of keep our comments efficient so we can start to go through all the questions that you guys have submitted in the chat box. And again, the only way to ask a question right now is through the chat box. So if you have a question, type it in and our team will flag it. Also, thanks to all of you who submitted questions beforehand. We actually went through those and there was a ton of responses. We went through those and kind of summarized the main themes. And so I'm going to start with some of those topics that were submitted beforehand. And Darlene asked you to kind of chime in on a couple of these. So first, Darlene, can you talk a little bit about the coordination that has to occur with individual emergency departments in order to not only just to get the legislation passed in the first place, but once you actually have that authority, once the bill is enacted, what has to happen to actually make sure it becomes a reality?
Okay. After a bill is enacted, then, and I believe this is true in all states, in Missouri for sure, then each local EMS service has a year to start looking at the education that they may need to provide and to also establish the new protocols. Normally, your state EMS association will also help with writing those template protocols. Let me back up just a minute. Every single state has a state EMS board, for lack of a better term. They may call it an association or something, but it's a board. And their job is to evaluate needs and resources, change protocols if needs to be. So that state EMS board is the ones that really need that we really need to make the collaborations with. And then they filter down from there.
Great, thank you. And can you talk a little bit from your personal experience about the different ways a family can package the information about the treatment protocol so that they can present it to their department and local department? Or in general, can you talk a little bit about, even if there is not this type of law in place, what are some of the things that you can do in your area with your EMS personnel to try to avoid this problem from coming up in the first place?
Okay. One of the very first things that each of you need to do is go to your specialist and ask for emergency medical orders. And the vital part of that is it needs to be orders. So it has to be on letterhead. It has to be signed, dated, with emergency contact numbers not older than a year. So you would get it updated every year. And it needs to be short, sweet, to the point, because it's in an emergency, do A, B, C, D. So that a paramedic has the instructions right in front of them of this is what I need to do, or this is what I don't need to do. Because for many disorders, literally even an IV for some rare diseases can kill that person. So the number one thing they need not to do is to start an IV. In a situation, you may think, oh, well, why wouldn't they just listen to a parent? Well, you may be overwrought, you may be distraught, not making sense, and you saying don't start an IV, don't start an IV, they would think was ludicrous and wouldn't know what to do. But if they have it in writing from a physician, they absolutely would know, okay, we cannot start an IV. And then preferably maybe that physician has an alternative of what they should do in your situation. So that is the very first thing. Second, go to your local EMS and your most local ER and ask for a treatment plan. And that will be a treatment plan for your loved one that has the rare disease or the special medical need on what to do in an emergency. It will cause them to do education. It will cause them to look at your situation. And then ask for a copy of that to also carry with those emergency medical orders. Because then if you're out away from your local facility and you have an automobile accident, let's face it, if you're a paramedic and you're able to pull emergency medical orders from a physician and then a copy of a treatment plan from an EMS service 4 towns over, then you're going to feel even more confident about, yeah, this is really the right thing to do. I can do this. Let's go. So it's just going to help take away that fear, help take away any uncertainty so that they know they're free to treat. Those are the best things. And then as far as your automobile goes, please be sure that you have your automobile clearly marked. If you have a bag with medication or necessary supplies for some kind of a medical device like a trach or a heart pump, be sure that they're in a clearly marked bag, that it is battened down. We use a 600-pound test carabiner with the bag hooked to a latched car seat belt so it doesn't go airborne. With a large medical alert symbol, I also created emergency alert headrest covers with a pocket that holds that documentation so they can find it in one split second. They're made aware this person has a special need. Oh, here's my information. This is what I need to do. Then if no one else in the automobile can speak, you're speaking for yourself at that point or for them. And, of course, wear emergency alert, medical alert bracelet, or dog tags. Basic ones, not overly fancy. They need to know it's a medical alert, that it's not a piece of jewelry, because you might not be in the car. You might be elsewhere.
Thanks, Darlene. And following up on that, there was a question about Duchenne muscular dystrophy specifically. We don't have information on what the emergency protocol should be for any specific diseases. If you have questions about that, I would encourage you to talk to your doctor or talk to other specialists about what those protocols may be. In addition, once you kind of reach out to Denny's Dose, if there's others in that community we can link you up with, we'd be happy to do that. So there are a couple of the questions here that I want to run through. So there's a question about the electronic medical records and whether those facilitate better communication about protocols between departments. Yes, potentially. So like the ability, like the existence of the internet, the existence of computers, mobile phones, and things like that could potentially make it easier for your doctor's orders to get to EMS personnel or to a emergency department. The problem is that there are no rules in place to govern or require that kind of transmission. And in general, medical records, electronic medical records, are not shared as freely between physicians and different providers as we would like. Some of that is because of legal restrictions pertaining to the use of patient information. So someone who has your patient information can't just send that to whomever they want, even if it's another doctor, without, in many instances, without your authorization. So as part of this work we're doing in states, we're trying to find ways to, in implementing these protocols and implementing these solutions, to make sure that they can be done electronically and that conforms with all the rules and regulations that exist around electronic health records. So yes, that is something that does potentially make it easier. There are proposals out there that we're looking at that would essentially require emergency departments to have some kinds of databases that exist in that way. That's a challenge to implement it. One of the things that we think maybe more of a low-hanging fruit to address this problem is standardizing the information that patients themselves carry or families carry, so that you don't necessarily require the emergency room physician himself to have access to a database where he can pull this information, but the information that the patient would present or the family would present would be certified in a way that the doctor recognizes that, okay, this is an order that I can follow, this is based on a specific physician recommendation that I should pay attention to. Another question about how does this relate to kind of other medical personnel, such as nurses and physician's assistants. So in the cases in most emergency departments, those emergency departments, the protocols operate and cover the other medical personnel operating under the emergency room doctor. For physician's assistants specifically, all physician assistants operate under the medical license of an overseeing doctor. So that kind of, because they operate in that way, if you allow the protocols in emergency departments, it gets around that issue a bit. The same kind of goes for EMS personnel. Paramedics oftentimes operate under a medical license of the regional medical director, and so if you establish that protocol and that authority at the director level, it often covers the individual different providers that exist below that. So quick question about the slide deck. Yes, these slides and the recording of this webinar along with the slides will be sent out to everyone who registered. It may take us a couple weeks to kind of get the recording format and things like that, but all this information will be sent around to you if you registered. In addition, some of the follow-up contacts and next steps that we discussed, such as that coalition, will also be sent around to everyone. Darlene, can you talk a little bit more about your family emergency preparedness events?
Okay. One of the things that we do, we go into much more detail because in the 3 years we've been working on this and working so closely with EMS, they have actually taught me, and I have asked them, what do the families need to do? So it's really about a 2-hour time frame. We like to bring in one or more of the local EMS services, and if we can get some of the hospital staff in, it's open to all rare diseases for the ones that we organize ourselves. And it's a day we try to have some fun for the kids and have them get to meet with EMS officials and get to climb all over the ambulances and see them, because in our opinion, the more familiar you are with something, the less fear there is. That works on both sides of the coin. The more paramedics and emergency officials that we have come to our events, the more they learn about the rare diseases, and they're able to sit back and say, oh, okay, this isn't as hard as I thought. And then we pull the parents out for a little bit of quiet time to educate you in detail on just thinking ahead and go into more detail about what that treatment plan really should look like, about having an emergency plan at school and a 504 plan at school, and then even like if AirVac needs to happen, to make sure you have a good plan on where that helicopter will land and what the best hospital is that your child needs to go to. So we go into very detailed information on a very good plan, and mostly based on the really good plan that the local, I'll just give them credit, Phelps County EMS service in Rolla, Missouri, really have one of the best plans that we've seen for anyone, and we kind of use them as an example.
Thank you. Another question about what is the best way to handle a situation like when you talk to your EMS department, when you talk to your emergency room physicians, you've told them your situation, and then when you have an emergency situation, they don't listen to you. Kind of what is the best follow-up to that? What can you do in that situation, either in the moment, after the fact, or even like beforehand, if they're saying that they're not going to follow what you're doing?
Okay. If it's beforehand, and I hate to say that this will happen, this has happened to our own family. For my grandchildren where we live, our treatment plan is that we will call EMS, they will treat, and they will transport to St. Louis, which is the nearest hospital that knows how to treat hemophilia. Because unfortunately, the other hospitals that are within an hour away have said that they really don't know about hemophilia, and the only thing they would do is stabilize and transport. So at least we know that ahead of time. At least we would not be taking our time. So sometimes the answer is no, and it doesn't matter how much you've tried. If a facility is not willing to treat you, then you just have to have a plan around that. So our plan is we will not go to the local ER unless it's absolutely cannot be helped. Now, if you're in the middle of a situation, of course, trying to be calm. The more calm you are, the more rational that you appear to everyone around, and the more likely you are for them to listen to you. There is not a 100% way to make an ER physician listen to you if they are unwilling to do it. You can ask for the hospital social worker to be called down, or try to call them yourself to have a second, have a liaison in there. If you have a home health company or a specialty pharmacy, by all means, if you're on your way to the hospital, I would also call them, because if your nurse with that company is anywhere close, they can sometimes come meet you there, and then you have another voice that's also a medical professional that would help them be more likely to listen. And then after the fact, of course, and we hope that everyone listening to us will go make their plans ahead of time, and we don't have to worry about the after the fact. But after the fact, of course, you can contact that hospital board. You can contact and ask for a meeting, and then to let them know the issues that you had, the problems they have in their facility, and ask to be part of a better solution.
And so there's a question about specifically, who you talk to first about that. In some cases, your health department may be appropriate and they can help facilitate that, but it sounds like it's always going to be best to talk directly to your local EMS department and those personnel to kind of figure out how to go about making sure they're aware of the situation, especially if you live in a rural area where you could likely meet the emergency staff that is going to treat your family in an emergency situation. Like, they probably will be the same. If they know where your house is, they know if they're going to show up to that house, they get a call, that person probably knows you personally in smaller towns. So I would encourage you first to go to your emergency department. In some cases, your county health department could be helpful, but working directly with those emergency staff can often be most productive.
Yes, and actually, in general, they usually are very nice, and I just Google the number and call them up and say, hey, you have a family living in your district that has this disease, and we would like to come in and have a meeting. We would like to set up a treatment plan, and we'd like to make sure that you guys have all of the education and training that you need, so that we can make sure in an emergency that everybody's protected. And most of the time they say yes. But at least if they say no, then and you can start moving forward with plan B. There's also, like I said, that state association. There's also a state medical association if you aren't getting anywhere with a local ER or a local hospital. So everybody does have a boss. And, of course, remember, you always want to be nice. You always want to create a collaboration and a partnership that is aimed at safety and proper treatment.
Great. And there's a couple questions about specific legislative efforts. So if you have a question about kind of what's happening in your state, like such as Idaho, or who the potential sponsors of legislation are, not going to cover that on this call. The best way to get that information is stay connected to us, and once we start figuring out and building the coalition out and building out more actions in individual states, we'll share that information with you and also provide more state-by-state information about how to get involved. So finally, Darlene, can you talk a bit about the federal bill and what that seeks to do and who it would cover?
Okay. Back in like 1980, there was a bill created with federal grant money set aside specifically for proper treatment for children, because at that time, none of our ambulances had anything sized for a child. They didn't really have training, and if anyone is familiar with treating children, and every pediatrician will tell you, kids are just different. The way they absorb medications, everything. So at that time, an organization called EMSC, Emergency Medical Services for Children, was created. It's a national organization. I am pleased to say that they have contacted me about 2 months ago, and I am on an advisory team for them to help be the voice for our rare disease group. Under that legislation, there's money for each state, and there's guidelines as requirements for receiving that money, and they have to literally show proof of corrections to existing protocols and successes. There's a lot to that grant money. And so our federal bill, what the thought process was that it would be better to go under that avenue so we aren't asking for additional funds, because we know that our government budget is so tight, and to just add additional requirements. And I do want to add, although this is legislation for treatment for children, there is not a regulation that would ever say, oh, you could treat a child, but you would have to let an adult die. They just wouldn't do that. So basically, you take an avenue that will cause a situation and an issue like this to be looked at, for solutions to be assessed, and then for solutions to be implemented, and it will automatically be for children all the way through adults.
And so to be clear, what you're saying there, Darlene, is that essentially the same authority that would allow these protocols exist to apply to children also kind of by default applies to adults. All right, so a couple more questions. So there's a question about basically how do you go about building that report? I mean, the best way are your orders is to work with your physician or a specialist. You may also have some success if your normal physician doesn't quite have the expertise to develop that. You might be able to get an outside physician who's not directly treating you to help you develop those protocols. A question about going out of the country and how this applies out of the country, that really depends on the country you're going to. The best potential way to address that is if you have those orders, to make sure that they're potentially translatable into the country you're going to. If you're going to Europe, most physicians over there would speak English, but if you're going to someplace where English is not necessarily the primary language, if you have your orders, you may want to translate them into that language. In addition, if you're going into an extended stay in a country where you anticipate, you could have an issue, the same strategies that work in the States could potentially work there, which is to talk to those emergency medical departments ahead of time. And so if you're staying in one city for a while, kind of figure out and do your best to kind of talk to emergency physicians, or at least at a minimum, if you're staying in a hotel, talk to a hotel staff who maybe can help you in the event that you have an emergency like that. There's a question about specialty medications and how hospitals stock them. So this doesn't relate, these EMS protocols don't relate specifically to which medications hospitals are able to stock or not stock. That's kind of a separate set of policy questions that has the hospitals themselves have a lot of discretion over that. However, I think the same strategies here could potentially apply to that issue. So if you know that in an emergency situation, you or your child or a loved one relies on a specific medication that is often not in stock in hospitals, you could potentially talk to them beforehand and see if they can make accommodations, knowing that you're going to go to that hospital in an emergency situation to carry it.
And Tim, that's where that asking for a treatment plan comes in. So you should ask for a treatment plan with your EMS service, and then you should ask for a treatment plan with your most local ER or plural ERs and EMS services. So if it's city and county, or you live close to one, but where school is or work is close to another hospital, you should go visit all 4 of those.
Mm-hmm.
It's better to be well more prepared than you maybe ever need to be, but you never know.
Yep.
And in that treatment plan, that's when you would ask them how they would handle your medication. And that's when they would either write for the allowance to use your meds or maybe keep some on a consignment basis or whatever you could work out.
Yep. All right, so our final question is about what's the best way to get those medical records or orders to your emergency medical personnel. There's a suggestion of a USB thumb drive. It really is based on what their preference is. I know from personal experience, many hospitals are going to be highly hesitant to plug a personal thumb drive into their computer system because of hacking concerns and HIPAA things and like that. So I'd really talk to your local departments and local hospitals. Okay, how do they prefer to have that information? Some of them may say email it to us. Some of them may say, yeah, thumb drive is fine. Some of them say, please laminate it and keep it on your person. There's really no best way, but be very cautious about any kind of electronic drive. They may be too sensitive to just plug that into their computer to access it. All right, well, thank you for all the questions. Sheikha, I'm going to hand it back over to you.
Sure. Thank you both so much for your presentations on this timely and important topic. Our community really needs to rally around and mobilize around this issue, and it's through both of your leadership and through the participation of our community that we'll be able to make a dent on this issue. So thank you so much. Following this webinar, we will be sending quite a bit of information on how to get involved in this issue and connect with Darlene at Danny Stoves, as well as engage with RAND. So look out for that email. If you had a question that wasn't answered during the webinar, please feel free to email us at education@rarediseases.org, and someone will follow up with you. In addition, we'll be sending out a short survey. It's really helpful when you all fill out those surveys. They do help us develop future webinars. Thank you all so much for joining us. Have a wonderful day.